Thank you. I'm grateful for the opportunity to present our cost-benefit model for antibiotic treatment at end of life. Antibiotic resistance has become a major global concern. A report that was submitted by the CDC to the President Barack Obama in 2013 presented the high mortality and morbidity rate that is inflicted by resistant bacteria, as well as the huge economic burden that is also inflicted by this resistance. In Israel alone, the estimated mortality rate due to hospital-acquired infections is between 4,000 to 6,000 people each year, mainly due to resistant bacteria. So what is actually so unique about antibiotics? It's a relatively simple intervention, and it has the potential to turn a lethal condition into a completely reversible one, and this is very unique in medicine. We also know that correct and antibiotic treatment improves survival for severe infections if it's given early, between 24 to 48 hours from infection onset. And usually this has to be done even before the pathogen is identified. And the knowledge that antibiotics are so useful and so life-saving is a major driver for antibiotic use. And excessive or unnecessary use of antibiotics is very common, and at the same time it promotes resistance without any benefit to the patient. It is currently threatening to exhaust this precious resource, and on top of all these, development of new agents is lagging behind resistance development. So given all these, we can actually assume that antibiotics can be considered as a non-renewable resource. At end of life, antibiotic treatment is often considered as futile because it confers no benefit to the patient, and as I mentioned earlier, it promotes resistance development. From previous studies, we can see that 90% of advanced cancer patients were treated with antibiotics in the last week of their lives. And among nursing home patients with advanced dementia, 42 patients were prescribed antimicrobials during the last 2 weeks of their lives. And one more interesting finding comes from Korea, observed that nearly 60% of patients who died in medical wards and had a DNR order were still treated with antibiotics even after the order was issued. Antibiotic stewardship is the strategy that aims to achieve the optimal clinical outcome, namely cure for the patient, while minimizing toxicity, namely adverse events, and at the same time minimizing the ecological impact, namely resistance development. It is a challenge in clinical practice, and especially at end of life. And we can see that at end of life, the high incidence rate of infections and the fact that patients are often exposed to healthcare systems, and they are mobile within healthcare systems, as well as often they carry catheters and devices, and they need many more contacts for the nursing needs. All these actually increase the risk both for harboring resistant bacteria and to transmitting them to other patients. And on top of this clinical challenge, it's of course a difficult topic, and decision-making at end of life is not an easier practice. There is no consensus existing, and it is tended to be avoided. So one possible solution for such complex decision-making process might be a computerized decision support system, and TREAT is such a computerized decision support system. It is in clinical use in medical wards, in 2 medical centers, in Rambam and in Beilinson. It is based on a causal probabilistic model and also on a cost-benefit calculation, which currently doesn't account for end-of-life considerations. The ecological costs are antibiotic-specific and not patient-specific. So our objectives in our study were first to assess the obstacles and the challenges of antibiotic stewardship at end of life through an attitude survey among healthcare practitioners. Then modification of the cost-benefit model for antibiotic treatment at end of life, first by developing a predictive model for imminent death, then by modification the cost components for end-of-life conditions, balancing between the two, and ultimately reducing futile antibiotic treatment. So we conducted a survey among 274 healthcare practitioners at Rambam and Beilinson. As for antibiotic treatment, we found that nearly 34% of healthcare practitioners were in favor of antibiotic treatment at the end of life, which is quite similar to the rate of healthcare practitioners who were in favor of invasive interventions, and that was nearly 32%. These two stood in contrast to the non-invasive interventions, which like dialysis, surgery, ventilation, which were favored by 81 the invasive interventions, including what I've just mentioned, and the non-invasive intervention like hydration and blood products were favored by 81% of healthcare practitioners. As for perception of possible harm, only 59% of the participants perceived antibiotics as potentially harmful both to patient and surrounding. And as for antibiotics and shared decisions, only about 30% of healthcare practitioners considered family as partners for decision making when it comes to antibiotic versus 72% of practitioners who considered family as partners for other life-sustaining interventions decisions. Now I wish to present the actual model within the treat system. So the first component is the benefit, and the benefit is divided into two parts. First of all, survival, 30 days survival. This is the perspective we are referring to when we're dealing with infections, and I highlighted this component in yellow because this is a component that we are individualizing. The other benefit component is reduction in hospital days. We thought this was a bit less of less relevance because patients at end of life will often be hospitalized in some kind of healthcare system, whether it's a hospice or a general hospital. And as for the cost component, it is also divided. This time it's divided into three parts. First of all, the drug itself, the drug, the administration staff that is needed for administration, monitoring, blood tests, etc. Then the adverse events like Clostridium difficile, diarrhea, allergy, renal toxicity. And what's most important for us was the ecological cost, which is also being individualized. And this is divided into ecological costs for the treated patient and ecological costs for other and future patients. So just to summarize this slide, the components highlighted in yellow are the ones that we're modifying. Now I'll focus on the benefit. As I mentioned earlier, our perspective is 30 days survival, and we developed a predictive model using a very large cohort for imminent death, and the variables that are presented here were associated with curtailed survival, for example, congestive heart failure, malignancies, liver disease, poor functional and poor nutritional status. And we validated this model on two other cohorts. It was highly predictive, and we implemented it on a cohort of 463 patients, medical inpatients. We observed treatment modification in nearly 9% of this cohort, 41 patients, and within this subgroup of 41 patients, mortality rate was 46%. The ecological costs were decreased dramatically from the 100% represented by the pink column to 30% represented by the green column with the new model. And the blue column represents the actual costs of the ecological costs of the treatment as it was prescribed by physicians, and it was summed up to 83% of the standard advice of the system. Now I'll focus at the ecological costs. As I mentioned before, it is divided into ecological costs for the individual, the treated patient, and this is comprised of patient's risk for acquisition or selection of resistant bacteria, and the risk for a new infection in the month following the index infection, and of course the mortality that is increased by losing a treatment option due to resistance. The following variables were found to be associated with these risks. For example, place of habitat and poor functional capacity, cognitive capacity, catheters, devices. And all these variables were also associated with the potential of the treated patient to transmit his resistant bacteria to other patients. So just one example to make it more clear. If we look at two patients at the same age, the risk of a bedridden patient coming from a nursing home to harbor and to spread resistant bacteria is much higher than the risk of an independent patient at the same age coming from community, from his home, for example. We chose to assess this model according to three theories of distributive justice and to try and reconcile possible dilemmas and possible contradictions. And within this context, I just want to highlight a few key definitions. When we say to each according to her utility, we should ask ourselves whether the dying patient has the capability of turning antibiotic treatment into some kind of utility. And the second question, to each according to her need, we should ask ourselves whether antibiotic treatment really fulfill the dying patient's need. We assume that the dying patient has many other health problems, of course, and antibiotic treatment may not necessarily indeed meet his needs, fulfill his needs. And equity in gain, we believe that equity in gain can be achieved by preserving this resource and letting other generation and future patients gain better health by using it. We have to acknowledge some challenges and limitations, of course. Behind the scene decisions that are not completely transparent to the user at the end point, at the point of care. The physician is not a part of the calculation done by the system, and this fact might provoke some antagonism among clinicians. And decisions about antibiotic treatment will still be taken without consulting family and patients, just as they are nowadays. The age-related bias in treatment of patients, and this is solved by the system. It is already embedded by the system that age is not a factor for treatment. What I mean is that the system assumes the same life expectancy for all patients who are expected to survive the 30 days, regardless of their age. And we also have to deal with religion, religious observance, and cultural diversity. I wish to summarize. First of all, this is the first attempt to try and deal with such complex decision-making process and ethical dilemmas through an explicit model. And the implementation of the predictive model for 30 days mortality resulted in significant reduction of ecological costs for antibiotic treatment at end of life. The ecological costs individualization is still in progress. Thank you very much.
Thank you, Yael. It was